Today, the topic for the discussion is burns. Why a plastic surgeon talking about burns? Burns is managed by many specialties in the world, starting from plastic surgeons, general surgeons, pediatric surgeons, and there are specialized burn surgeons in some countries. Uh, uh, in Sri Lanka, currently, I think still most of the significant number of burn patients are managed by general surgeons, and there's another significant portion managed by plastic surgeon because there are plastic surgeons in the different areas in the country currently. Plastic surgery is one of the broadest specialties in surgery, where we have reconstructive surgery. In that, there's burn-related reconstruction, hand surgery, peripheral nerve surgery, correction of deformities, especially involved in the face, like in cleft lip and palate, and congenital deformities in the hand. And in addition, covering of large soft tissue defects following trauma and following cancer excision. So, likewise, there are different areas that we are dealing in plastic surgery. Today, our
What is that now? Can you just tell now people when we hear plastic surgery, we talk cosmetic. In a tertiary hospital like that, how many percentage of cosmetic surgeries that you do, and how many percentage of
cosmetic surgery? I would say almost nil. Say because we don't have resources to facilitate cosmetic surgery, because cosmetic surgery is changing one person's appearance when they have normal body structures. For example, if they have a normal nose where they want to change the shape of the nose, so that is a cosmetic surgery. So we generally we don't do cosmetic surgery, but if there's a functional or a problem involved in, say, if there's a nose deformity with difficulty in breathing, so we do it. So it's likewise we do as a reconstructive form, not as a cosmetic surgery. So cosmetic surgery is a very small percentage of plastic surgery.
Yeah. How many plastic surgeons are there in the country at the time?
Currently about 19 plastic surgeons.
Okay.
So I will, Rohan, I will proceed with this.
Yes.
So burn injury and management, it involves a long history. And if you take recorded evidence for burns and burn management, it goes long back to the Neanderthal cave paintings. There are paintings with burn injuries, and they are managing the burn patients. So if you take from there, in pyramids, there are recordings in their papyrus paintings, and in Indian history, in Sushruta Samhita. So all those ancient documents give evidence that people have managed burns. Now, currently, I know there are some people who use honey for burn wound management. That had been doing by people who are living in ancient Egypt, who built the pyramids. So they have been using honey for the management of burn wounds. So it has a very long history, probably from the time that we start using fire as humans. So we have had burn injuries, and people have developed ways and means of managing their wounds. So when it comes to the burn, so it's a spectrum of presentations. For example, minor burn of your fingertip while you're cooking, to a major burn involving the almost all the body, amounting to 100% burn. So it's a spectrum of presentation of various clinical scenarios in burns. And in hospital setup, if you take, it's a relatively common form of trauma, and this can result from thermal burns. Thermal burn is the commonest way of presenting burns. So thermal means it can be a flame burn, It can be hot contact burns. For example, if you touch a hot plate, or if you touch a very hot metal plate, so that's a contact burn. So it's a thermal contact burn. So thermal flame burn means that you get burned with flame. For example, if you are lighting something, you're lighting a pile of garbage, then you can get flame. Or if somebody sets fire to themselves using petrol or kerosene onto their body, so it's a thermal flame burn. And then we call scald. That means hot liquid burn. The commonest one is hot water burn in children, hot tea, hot milk, hot soup. So they are scalds, or liquid material containing heat. Rarely you get hot liquid plastic, liquid tar. They can also cause scald. So they are all thermal burns. So that is the bigger category of burns. Then comes electrical burns, where you get in contact with live electricity. It can be domestic, low voltage, electrical contact wires, where you get burnt at the site of the contact. Sometimes you can get high voltage electrical burns, where you get a flame arcing onto your body, as in high voltage lines, like in 33,000 voltage, 66,000 voltage, or in lightning. So it's a flame burn in addition to electric current going through your body. Chemical burns, it can be acid, alkali, or other chemical material which interact with your cells and causing damage. So commonest chemical burn in our environment is acid burns, where you get exposed to the acid accidentally in handling, like in labs and in factories, or as an interpersonal violence. Some people throw acid onto the other person, so it's an acid assault burn. So that is the commonest chemical. But in addition, alkali burn, like in corrosive substances. For example, people use strong alkali to stop setting the rubber. To keep rubber as liquid, they use strong alkali. So that can cause burn. So in addition, physical burn, that is basically I included as a friction burn, when your body surface is dragged over another surface, where you get physical damage to the surface, and then it generates heat also. So that is a friction burn. And in addition, you get burn due to extreme cold. For example, now in refrigerators and in air conditioned machines, you have coolant gas. So that is a very cold solution. The mechanics who work in such industry, they sometimes come with cold burn. So due to the extreme low temperature, the cells can get damaged. So these are the common modes of trauma or in the field of burn. So this can be a minor injury, or it can be a potentially life-threatening injury, depending on the extent of the body damage. So in the burn, there are a lot of aspects to talk about. So starting with the burn management actually starts at the site of burn. So that is the most important part of the management, which most of us does not attend properly. Then the resuscitation, where the patient comes to the hospital, you do the initial resuscitation. That is the second most important part of the management. And then assessment of the burn wound, the fluid resuscitation, the wound management, the dressings, and the surgical procedures that you do in terms of achieving early healing of the burn wound. So in addition, the pathology and pathophysiology involves a metabolic response. So, and part of that, the systemic inflammatory response syndrome and things like stress ulcers involved in the stomach and duodenum, they are all part of that. Nutritional support is important because these patients, they are in a negative or the catabolic state. So there are energy requirement and protein requirement is very high. So you need a special nutritional support in terms of achieving good wound healing. Control of infection is very important. A superficial burn today can become a deep burn, and it can determine the outcome if you don't attend to the infection. Inhalational injury is important part, but which is not very common in all burns, but it is seen in major burns and where your respiratory system, the airways and the lung is involving in the burn. It's not direct flame burn, but the inhalation of hot smoke and fumes and noxious gases. Management of scars, contractures and deformities, that's where actually we fit in as plastic surgeons, because most of the time people can manage and they will manage burn patients, and then if they are superficial they will get away without any problem. But when they have a deeper burn, they heal with scar tissue, leading to bad scars, contractures and deformities, where we need to reconstruct them in order to achieve a successful or functional good outcome. So all burn patients need psychological supports, and their psychological aspects has to be addressed. Some of the burns can be non-accidental burns, and where interpersonal violence can be involved. So medical legal aspect is also there. So these are some of the aspects in management of the burn patient. Most of the areas I'll be touching in the subsequent slides of my lecture. So I will proceed. So when you take the burn wound, so this is the three-dimensional classic description of the burn wound. We call it the Jackson's model of three-dimensional burn wound. So this was described in 1947, way back, but still that is valid. So in the center of this picture, you have the zone of coagulation, where you have the necrotic or the dead part of the skin or the tissue. So that is called the zone of coagulation. It's already dead. It's gone. Around that, you have the zone of stasis. It's a marginal zone where you try to preserve. Otherwise, if you don't attempt to preserve that region of zone of stasis, it can become zone of coagulation. And then around that is the zone of hyperemia. You know, in response to the tissue injury, you get hyperemia as part of inflammatory reaction. So if you go back to your basic sciences in pathology, burn is an injury, and in response to the injury, so a body is producing the inflammatory response. So probably, Rohan, you can ask the junior guys, what are the other features of acute inflammation?
Only that.
Yeah.
Clarify one thing. You
Yeah.
said, three zones, and zone of coagulation, stasis, and hyperemia. So if I tell the zone of coagulation cells are already died, they have gone, they are already dead.
It's dead and it's not viable. It's necrosed actually.
Zone of stasis, there are cells which can be salvaged. Or is it correct?
Yeah, it can be salvaged, provided you give adequate amount of perfusion in terms of nutrition and oxygen. So the aim of resuscitation is partly to preserve this area.
Okay, right. So we are mainly, when we are managing these patients, we are worried about the second zone.
Second zone, yeah.
Okay.
And then even the third zone, the zone of hyperemia, can be extended if you don't provide adequate perfusion. Perfusion means the blood supply to the tissue to maintain their viability of the cells. So what you need is the oxygen and other nutrients from the blood.
Okay. Right.
Okay. So Kolita,
Sir?
Now the zone of stasis, zone of coagulation is already dead. You can't do anything to salvage that.
Yeah.
And you are trying to prevent it extending to the other zones.
Yes.
Or to sort of preserve the other zones as much as possible. Now, is there any time frame where we should act to preserve other zones, or it is as soon as possible.
Yes. From the time of burn, we have to address this. So from the time, so timing wise, from the time of burn. But unfortunately, most of our patients which comes to the hospital has lost that golden opportunity of managing from the time of burn.
Right.
So I
So
will
what you are saying is sort of, this needs urgent attention. So
yeah.
you can't wait for a plastic surgeon to see this patient.
No,
So
no,
any
exactly.
medical officer should
Yeah.
act and sort of should
Yes.
have knowledge to minimize extending this zone of coagulation to the other zones.
Exactly, sir. Exactly.
Shall we ask from our registrars,
Yeah.
what are the principles or what are the methods of, or what is the main principle of avoiding extending the zone of coagulation to the other zones?
Yeah.
Can one of the registrars answer?
Yeah, first thing is we have to maintain adequate circulation to the these surrounding the stasis area. Otherwise, the blood supply via the nutrition will does not come to this area. It will die. Therefore, initiate resuscitate with fluid to adequate blood supply to this area is important, I think, sir.
So you think the most important thing is fluid resuscitation. Anyone else?
Yes.
So as for the initial management, the main injury comes from the heat. So if the heat persists, and then zone of coagulation will increase. So
Okay.
initial management with thorough irrigation with cool water, not cold water, but just tap water, at least for 5 minutes, more than 5 minutes. Actually, that will reduce the progression of the heat burn extending towards the zone of stasis.
Okay,
So
you think
that
the
is
cooling is the most important thing. Okay, anyone else? Anything else? Can you hear?
Yeah.
Okay, if I ask in a sort of a best of 5 question, the main way of reducing the spread of zone of stasis or the dead tissue, dead area of burn, cooling the surface, fluid resuscitation, IV antibiotics. We take those 3. Which one is the best matched answer?
It's the cooling, sir.
cooling, sir.
Okay. Kolita?
Yeah. What is
Yeah.
Now it depends on the timing. Say if the patient is in the hospital,
Yeah.
so that means that cooling part that opportunity has lost. So if the patient is in the hospital, the resuscitation is the answer. If the patient is in the field, cooling is the answer.
So
Okay.
in
If
simple
they
words-
come early enough,
Yeah. In
cooling is the
Yeah.
best thing.
So in simple words, sir, if you pass the message, the management of burn start from the time that it happened.
Yeah.
If that message goes to the students, that should be a good
Yeah.
thing.
So in fact, these things are there in subsequent slides.
Okay, right. Okay.
Yeah.
Oh,
So if I touch a bit of pathophysiology, when you have some form of damage to the cells or the skin due to heat or electricity or chemicals or mechanical damage, and there will be inflammatory response. In that, specific to the burn, there are a lot of inflammatory mediators which are acting on local as well as in systemic manner. So one important cell here involves in the pathophysiology is neutrophils, polymononuclear neutrophils. They adhere to the endothelium in the affected area, and then they release various inflammatory mediators, and endothelial cells and platelets also involved in the process, and they also release various inflammatory mediators. And they have observed profound vasodilatation at the local site, as well as in large burns, even in unburnt areas. So there's generalized vascular permeability especially in major burns. So in addition, there had been they have seen proteases, oxygen free radicals, peroxidases. They are all like cell damaging agents. Especially now these things are, if you talk about refurbishment injury, these things they are causing the cell damage. Similarly, you have all these cell damaging factors. And then there's these peroxidases, which lyse the cell membrane lipid, causing further cell death. And in addition, they have noticed that increasing the intercellular gap formation, all these leads to increasing the vascular permeability, promoting edema. And there had been, they have seen areas of thrombosis as well. So in addition, the transmembrane potential has been changed. So all this leads to increased permeability in the local site, as well as this involves the whole body in major burns, producing massive fluid shift in the rest of the body as well. So as the burn area increases, the systemic inflammatory response ensures. A significant fluid shift from the intravascular compartment to the extravascular. That means the blood is there in the intravascular compartment, which leaks out some parts of the blood, especially the fluid, the electrolyte, and the proteins leaks out. This happens in the first 24 hours. So this will clinically manifest as edema. The rate and the amount of the extent of the edema depend on the burn surface area and the depth. The larger the burn, you get more edema. So likewise, in smaller burns, the edema peaks early, especially in that local area. Does not involve the whole body in smaller burns. But in large burns, when they are more than 35-40%, the edema involves the whole body, especially the unburnt areas as well. So this is important in the management, especially say if the patient is having lower body burn, and if they develop massive edema, so that they will develop edema in the upper part of the body also. So you have to think about upper airway obstruction and problems like that.
Excuse me, Kolita, I just want to clarify a few things. You said the intravascular, the capillary leaks leading to extravasation of fluid. Is it plasma which leaks out?
Yeah, plasma, especially the water, electrolytes, and proteins. Yes.
Is it all proteins or albumin?
Mainly albumins.
Right. And you said it starts from the time of burn and it finishes by 24 hours, or sort of it's minimum, it becomes sort of less significant after 24 hours?
Formation, the increased vascular permeability reduces after that. So it does not progress after that.
Right.
This happens at the initial, very first, the day one, first 24 hours.
Right. And then you said the amount of fluid leak. Can you hear me?
Yeah.
Yes.
Hello?
Yes.
Can you hear me?
Yes.
Hello?
I can hear you.
Hello?
Can hear?
Yes, sir.
Hello? Can you hear me?
Yes, sir.
What happened? Hold it.
Yeah, I can hear you, sir.
You can hear me?
Yes, yes. Yeah.
The amount of fluid leak is proportionate to the surface as well as to the depth.
Depth, yes.
But when we are calculating the amount of fluid, we take into consideration of the surface area, but not the depth, isn't it?
Yeah.
Are you coming to that later, or?
Yeah, I'll be coming to that later.
Okay.
Okay.
Yeah.
Right. Only just one more question.
Yeah.
Now why are we now? Let's say someone comes with a laceration, same size laceration in the forearm and a burn. Why are we really worried about this vascular response and why is it different? Why burn is different to any other wound? Is there a difference, or why if it is?
Yeah, main problem of the burn wound is the massive fluid shift that happens this is, but especially this is very peculiar in burns. But in some of the other conditions, like say if there's significant say conditions like epidermolysis, conditions causing epidermolysis of the skin, still that can act like a burn, because the moment you lose the surface cover, the response can be similar.
Okay.
Does that happen in all types of burn injuries, or only the heat burn?
No, this can happen in all types of burn injuries, but the amount of the response can vary according to the surface area. Say if the burn is involving only the say only the forearm, so you will not develop systemic manifestations, like you won't develop systemic edema in that case.
So for you to develop a systemic response, do you need some kind of percentage involved?
Yeah, more than about 35 to 40%.
Okay.
Yeah.
Yeah.
Oh yeah, yes. For
Yeah.
burns, what from up to now what he said, what is special about burns is the disproportionate local and systemic response that the patient develop, and in the initial management, the fluid shift initially locally, but if the burn is large enough, it becomes a generalized response of with fluid leak. That is very important. The acute stage. Is that correct, Corey?
Yeah, that is correct.
Okay. Shall we proceed?
So in burns with more than about 35%, there will be an increase in total body capillary permeability. So that's why you get most of this generalized edema. This is partly related to histamine release. It's a vasodilator, and the rate of tissue edema, development of the edema, it's a sign of adequacy of resuscitation. So while you are resuscitating, that means you are seeing edema. So in a way, it's a good sign. That means that what you are giving, you are giving some fluid. So it's a clinical feature that you are giving adequate fluid. So if in a large burn, if you are giving fluid, and if you don't see edema, then that's a sign that you may be giving inadequate amount of fluid. But this is not the marker to assess the adequacy of fluid resuscitation, because I'll be discussing that later. But just as a general sense, we see the development of edema means that he has had adequate amount of fluid.
Yeah.
So in burns, what they develop is basically a hypovolemic shock due to the increased vascular permeability. And in addition, the hemodynamic changes that they have is decreased cardiac output, increasing the extracellular fluid, because this fluid which is extravasated from the vessels are gone and collected in the extracellular space, in the tissue spaces. And the plasma volume inside the blood vascular system is less. And then due to the inadequate amount of blood in the body, you get inadequate renal perfusion and then oliguria. So this urine production is the most important thing that is taken in the assessment of resuscitation or the adequacy of resuscitation. So I'll be discussing that in subsequent slides. So primary goal of our resuscitation is to restore and preserve the tissue perfusion. This is what we are counteracting the fluid leak due to the burn. So in major burns, the edema and the fluid shift is a thing that happens, that you can't avoid. So based on that pathophysiological things, in the management I'll discuss further how these things are important in the clinical management.
Sorry to disturb you, Koditha. We were saying in major burns.
Yeah.
How do we classify major burns and minor burns?
About say more than 35%, we take it as major burns in terms of pathophysiology.
in all ages, or is it different in pediatric age?
Pediatric age, it's actually in the resuscitation of, when you come to the resuscitation, the age, it's the same formula, but depending on the patient's requirements, say in pediatric age group, you have increased amount of fluid requirements, so you give more fluid. And it's actually now we generally don't classify as say in a percentage, this is major, this is minor. We don't classify like that. But for pathophysiological purposes, around 35% is, beyond 35% is regarded as major burns in terms of pathophysiological description.
Okay.
But
One
for
small
the management, we don't need to classify as major burns and minor burns.
Yeah, I have a question. When would you consider admitting the patient to the hospital instead of managing in PC
Yeah.
or patient
Yeah,
home?
there's a separate slide on that. I'll go to that later.
You got to that, okay.
Yeah.
Okay.
So, according to these questions that we ask, if you are coming to them later, you just tell us. Then we can discuss at that point.
Yeah. Please go ahead.
About 110 slides to.
Okay.
Good
Yeah.
one.
All right.
Yeah. It's a big topic because the textbook of Burns is bigger than Kumar and Clark.
But if we can't finish by, let's say, a sort of time, we'll stop there and then do it another day.
Yeah, because as we go on towards the latter part of the discussion, I think registrar's discussion is important, because when you come to the skin grafting, that sort of things, yeah. So probably we can split and we can do it tomorrow even. It doesn't matter for me.
Yeah.
Okay, yeah.
So give me a second, Rohan.
Yeah, sure. So up to now, what Koletha said was burns are special, different to other type of wounds, and then he said you categorize burns into four main types, but there are other small types as well. And then he said the important thing, there are 3 different zones, and the most important zone is a transition zone. And then he said the basic pathophysiology and the importance of fluid leak in burns. So that is what we discussed about. Yeah, hold there.
So burn management starts at the site of the burn. So as in any form of trauma, in the assessment of the patient, you have the primary survey where you assess according to the ATLS protocols, airway, breathing, circulation, and so on. And then the secondary survey. So for burns also, this is applicable. So you have to do the primary survey, secondary survey. So ideal circumstances, this has to be done at the site of the burn. So the proper immediate care is at the site of burn. So why major or the severe burns is a significant form of trauma and it's potentially life-threatening. So the initial care that you give at the site determine the extent. Extent means the body surface area, the percentage involvement of the body surface area, and the depth. How much is the depth of the burn? So these 2 factors are determined by the initial management. And these are the very 2 factors which determine the patient's outcomes in terms of morbidity and mortality. Say, if the percentage body surface area is large, the chance of mortality and morbidity is more. If the percentage of deep burn is more, the chance of developing problems in terms of mortality and morbidity is more. And in our experience, in general setup, more than 90% of patients which comes to our hospital, they come without adequate pre-hospital management. Let's see what is this what is this pre-hospital management and why it is important. So the extent of tissue damage or the skin damage due to heat, for example, will depend on 2 factors. One is the time period where the temperature or the heat is sustained. So if the heat is sustained for 2 seconds, versus if the heat is sustained for 5 minutes, you can understand the longer the heat is applied, the more the tissue damage. And then the amount of heat, say if the temperature is low, the less tissue damage. If the temperature is high, more tissue damage. So this is called the time temperature relationship, which was proved by these two guys by doing various researches. So the aim of pre-hospital care is to reduce either of these two factors or both factors. So that is the basis of pre-hospital care. So to stop the burning process, what you do, you remove the patient or the victim from the source of injury, and then you have to stop the burning process. So important thing, you have to be very cautious not to become another victim. Sometimes we see the burn victim survives and the person who's going to help the burn victim dies due to a major burn. So this should not happen. So the first thing is you have to stop the burning process. So this is what you do, stop the burning process. These are two small posters designed to educate small children. The way that you extinguish a flame or the fire on your body. What you do is you don't run, you stop. And then cover your face. That is to prevent your face getting injuries. Drop on the ground and then roll. So you can see in the slides, stop, cover, drop and roll. So this is very important. Most of our patients, when they have flame on their body, what they do is they run, and then that will produce more and more flame because they get more and more oxygen. So they don't stop, they don't drop, they don't roll. So if they don't do this, then you are not extinguishing the flame, and then you are getting more and more tissue damage. The area of the zone of coagulation becomes large, and then you are ending up with a bigger percentage burn with a bigger deep proportion, and so your outcome of burn is going to be very poor. So what you do after extinguishing the flame, when you stop the burning process, what you do, you have to pour water, running water on the burn surface area. Now I'm discussing this in relation to thermal burns. And then on a person's, after a burn, there can be heat reservoirs. For example, burning clothes or a belt or ring or wristwatch. Such things can be removed if you can do it safely. By doing that also, you are reducing the amount of heat, the duration of exposure, and then you are going to reduce the burn damage. And then the cooling burn, what is this? This is not reducing this is not applying cold stuff. This is using the water of room temperature to run over the burn surface area. So this is a very good, very effective analgesic. Probably you would have had experience when you have a burn. Say if you have a hand burn, if you put your hand immediately under the running water, you will get a good pain relief. So this is very important. So they say by cooling, it reduces the production of inflammatory mediators. It reduces the amount of tissue damage, and then that's why you have the maintenance of the zone of stasis is achieved by cooling the burn. And simply you cool, you stop the flame, you start cooling, which helps to prevent the progression of the damage. The zone of coagulation will be smaller, and zone of stasis will be smaller if you do these two things. How do you do cooling? Sir?
We call it that. Now we said sort of cooling the body by using running water of normal temperature is the first thing you should do once you get the patient away from the source of burn.
Yeah.
So when you use, if you use cold water,
yeah,
I'll come to that, sir.
I'll come to that. Now, now what we tell the public is use tap water or running water because it is readily available. You don't need to run for cold water. But in research, they have shown any water between 8 to 25 degrees is useful. Ideal temperature would be at 15 degrees. That is in research. But you don't need to tell this to public because this is for our knowledge. Because if you say 15 degrees, people will go and put water into the refrigerator and then cool it. So that is time wasting. That you should not encourage. So what you have to tell is just normal water, maybe from the tap, maybe from the well, whatever you have, you use it. Minimum duration of application is 20 minutes. Generally, when I tell people, I say 30 minutes, half an hour, easy. So this is effective within first 3 hours following burn. So why the importance of knowing this is, so if the patient had a burn about an hour before coming to the hospital, so still patient is within the first 3 hours following burn. So giving a half an hour shower is still useful to reduce the burn. When you have a burn on your surface, or maybe from one of your known persons, ask them to put your burnt area under tap and keep for half an hour. And then after half an hour, you take the burnt area out of the tap. Still, they will have burning sensation. Then again put. So you can do this several times to see the time that you have the burning feeling. You have the burning feeling means that still that process of heat damage is continuing. So this can happen even up to 3 hours. So these are all shown in various researches. But the usefulness of that is even if the patient comes a bit late to the hospital, even still within the 3 hour range, you can give a shower, no harm in giving that. So you have to do this with caution because in these patients, sudden drop in temperature can happen, leading to hypothermia. So hypothermia can be a dangerous situation. They can develop asystole, they can develop ventricular fibrillation, especially in extremes of age in small children and in elderly. The problem is if the patient is unable to tolerate this shower, then you take the patient out and then you can put them back after some time. Other thing is if the limb is involved, you can only put the limb under the shower. You don't need to put the whole patient under the shower. So it is only the affected area has to be cooled, not the whole body. And ice and ice pack should not be used because that can cause cold injury in addition to hypothermia. So we don't generally encourage people to use ice and ice water, just tap water. The important thing is when you do this, you have to be cautious, and when you have to have your ABC, all those things in your back of your mind, because they can have a cervical spine injury, they can have a bleeding wound. So you have to be aware of other injuries. They can have a spinal injury. So you have to be aware of the other injuries that can be potentially life-threatening. So knowing that only you have to do this.
Gordon, can I interrupt one question?
Yeah.
Say, suppose you are in a cold country, like say in the UK or wherever, so the environment temperature anyway is cold.
Yeah.
You still have to do the the cooling by the water.
In fact, I have worked in Australia. What they still do is running water. In addition, they have packs called Burn-Aid. It's actually when you apply such packs on the burn surface, then you feel cold. So that absorbs heat. So there are commercially prepared packs. The only thing is it's not readily available in the society. Paramedics may have it. When you have a burn patient, when somebody calls, then they go and apply the Burn-Aid. So that is like applying water, but you can't wait till that. So best thing is to apply just ordinary water.
My point is that the environment temperature is anyways cold. Say suppose it's 4 degrees, 8 degrees. So what about what's the point of putting water into that?
Now this heat removal is better done by water than air, because the what do you call that?
Thermal capacity.
Amount of heat can be retained by water is more than air, isn't it? What do you call that in English?
Yeah.
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 So that's why you use liquid in radiator, not air.
Yes.
The specific,
Tapadharita.
yeah, Vishishta Tapadharita. I can't remember the English term. We're wrong.
Just can I just there is a problem with some students are trying to log in. I think I also can't find that. Now there was 260 logged in.
Yeah.
Reach the 300. I think now once it reach 300, I think you can't join. If you stand, but anyway, we continue.
Yeah.
Hmm.
So, in summary, cooling will be extremely effective analgesics. As I told you, it reappears. You can apply it, and then if there are no contraindication, you can continue till the burning feeling is gone off. When it comes to any question about cooling,
Yeah, the burning pain is a kind of an indirect.
yeah, it's a guide.
Okay.
It's a guide. Yes.
Right.
There are people, they have called me right at the time of burn, and then they say this area is burned. So I say put you under water, running water. Half an hour they call. So what do you apply? No, don't apply. Go back to water again. So you can do it several times. There's one patient. We were informed that patient is having 15% burn. And then we asked them, right, at what time? Right now. So we said, be under the shower, half an hour. So they did it 3 times. And then they said they were sending the patient. So initial description, they said, we have a 15% burn. So I was waiting in the emergency. So I didn't get any call after 4 hours. So then I went to the emergency to see where's the patient. Then the emergency doctor said, your patient is there. Why didn't you call me? Why should I call you? There's no burn in that patient. Then they said me 15% burn. Yes, there had been 15% erythema, 15% burn like erythema. Due to the successful application of water irrigation, it has become 0 burn.
Oh, really?
Isn't it important?
Oh,
Yeah,
So initial cooling is very important.
very important. Sir.
Right. Yeah. So when you
So-
are cooling, call it I can remember sort of when we were registrars, we were advised not to disturb blisters when you are cooling or when you are irrigating with fluid. Still, is it valid?
No, sir. We don't need to disturb blisters when we are cooling, but we in the management we take all these patients to theater under good anesthesia. We give a good scrub. We remove all the dead skin, and then only we start applying dressings. So I'll show the pictures in subsequent slides how we do that in theater. So in chemical burns. So what do you have to do is to dilute the chemical. So there will be residual chemical on the skin, and this chemical can continue to burn the surface till it is removed. So this can be done by, again, with water or washing with copious amounts of water or running water for a significant length of time. The ideal way of checking the adequacy of neutralization, the dilution, is by checking the pH, by pH papers. But we don't do it in practice. Say if the patient is burned with acid, then what we do is we start washing. How do we know we have washed it adequately? Is ideally by checking the pH. So what you do is you put the pH paper on the wound, a moist wound, and then you can check the color change. So that is the ideal way. But we don't have, but still here we go by the pain. So if the patient is having pain following the chemical exposure, we ask them to wash till the pain goes off. So that is a practical point. And then if sometimes these chemicals can be in powder form. So then in that case, you have to remove it mechanically, like using a brush. very important practical point is when you try to dilute this, you should not spill the chemical to the unburnt skin. Once there was a young patient had a acid spill onto the chest. So the patient was wearing a t-shirt. So what they did was they just removed the t-shirt the ordinary way from the head, and then that chemical on the chest area of the t-shirt was burn in the face also. So that is a dangerous thing. So you should not disturb, or you should not spill the chemical to the unburnt area.
Then in that kind of situation, how do you remove the shirt?
You have to cut it out.
Yeah.
You have to tear it, or you have to cut it. Like in any trauma, you don't try to remove the clothes ordinary way. You just cut it out, isn't it? Yeah. And then we should not attempt to neutralize the chemical. Neutralizing means if the patient is having a acid burn, you should not put alkali. So vice versa, you should not do, because so acid and alkali reaction is a thermogenic, and we don't know the exact strength of the agent that we are using. So you don't attempt to neutralize, but just to dilute it. So that is for the chemical. In chemical burns, especially acid assault burns happens on the face. So they get a significant burn to the eye. So important thing in the first aid is to continuously flush the eye. If you have water, then you use water. If you have saline, you can use saline. If you have a solution called balanced salt solution, that is the best solution, which is not available, but for theoretical purposes, that is the best. So that is the best to use for the eye irrigation. But whatever available, maybe water, maybe saline, you can use for irrigation. When you irrigate the eye, you have to retract the eyelids to open the phonesis and then to flush the phonesis out. Otherwise, the chemical will retain inside the phonesis, causing damage. Most of the time, these patients following acid burns on the face, at the time of presentation, their vision is okay, but they have not had adequate irrigation or dilution of the chemical on the eye. So they develop blindness later on. So that is an unfortunate thing. So it's very important that they do a proper eye irrigation, and then we have to get early ophthalmological eye surgeon's opinion. So otherwise they'll end up with blindness. Then we move on to the electrical injuries. Electrical injuries, as I told you, can be low voltage, can be high voltage. It can be due to the direct electricity, live electricity touching the surface, or it can be due to the electric current passing through the body, or it can be due to a flame coming onto your body following arcing. So whatever the method, you have to first switch off the live electricity off, and then you have help the person. So in electrical injury, the electricity, as it passes through the body, if it goes through the heart, it can interfere with the cardiac electrical activity. It can result in cardiac arrest or arrhythmias. So that happens right at the time of electrical current passage. Then what happens to the body is, when it goes through the tissue, it generates heat, especially in areas where there's high resistance. And then that heat damages the tissue. For example, if the electric current is going through a limb, and then it can cause muscle damage, it can cause nerve damage, and then later they will manifest as compartment syndrome. So this is very important. You will not see anything outside, but inside there will be tissue damage. And then this damaged muscle will release myoglobin into the blood and into the urine, and causing acute kidney injury. So this is a very important thing after electrical injury, especially high voltage electrical injury, to check into the patient's urine color. So in electrical injury, so there can be external burns, that is on the skin, or there can be deep tissue damage, that is the internal burn that you don't see outside. So we have to be very vigilant to detect the development of myoglobin in the urine, and you have to watch and wait, and then to pick the development of compartment syndrome if it is involving a limb. In this sort
Sorry
of
to disturb,
injury,
Kolita.
sir,
Kolita, sorry to disturb. Now you said in other two types of burns, whether it is chemical or thermal burns, the early cooling is very important. Does this apply to high energy electrical burns as well? When they are brought to the hospital, should we cool them as well?
yes, electrical burns, it can be, now as I mentioned, it can be, burn can be at the site of contact, especially in low voltage domestic electric current. If you touch a plug or electrical device with a live wire, so that point develop a burn. So mostly you see in the fingers this sort of burn. So that's a small burn wound, but it's a deep wound. So there you don't need to apply water irrigation, because that already that damage has happened. And the other variety is the cutaneous burn due to the flame. So when you have a high voltage electrical injury, the flame arcs onto your body, especially under high tension lines, and then in lightning. It is not only the electric current which goes through your body, it's the flame. So that is a thermal burn. On the surface, it's a thermal burn. So if it is a thermal, if there's a thermal burn involved, you can use the water irrigation. There's no contraindication provided the patient is out of danger from the live electricity.
Okay.
So, Kolita, just to clarify, so your water irrigation is just for the surface burns only, not
It
for the
is-
deep burns.
No, you can't do anything for the deep burn, because deep burn in the sense it's actually at the level of the muscle. So imagine you have the leg, and in your leg you have one of the muscle compartment which is burnt. Yeah, you can't do anything externally to prevent the damage. It has happened already, because it happens right at the time of the electric current passage.
Yeah.
So electrical burn, I'm telling again, small burns at the site of contact. So that is in low voltage electrical injury. In high voltage electrical injury, it is surface burn due to the flame arcing onto your body. That is from high voltage, like say 33,000, 6,000, and then in lightning. In addition, this high voltage electrical current passes through the body, causing deep tissue damage, especially in the limbs. So there are three faults that I described in electrical.
Okay. Then
The most
just to clarify now, in electrical burns, high voltage electrical burns to the limbs, we have to pay very cautious attention to the development of compartment syndrome.
Compartment syndrome.
Not
Yes.
like other two types of burn,
No, sir.
right? Yeah.
Yeah.
So you mean, you might be sort of describing how are we going to recognize it and sort of what sort of early intervention should be done. Okay.
Yeah.
Sorry, wouldn't you be worrying even there's circumferential burn in a kind of a limb?
Yeah, I'll discuss that in the section of sclerotomy, Aruna.
Yeah.
But probably, sir, Somudu sir, now since we are here at the compartment syndrome,
Yeah.
probably we can discuss a little bit about compartment syndrome. Aruna,
Yeah.
for registrars and senior registrars,
Yeah, I think. Yeah, sure.
it's just, yeah. So muscle damage in burns, it's just the muscle and the nerve damage inside.
Yeah.
So muscle ischemia, and then produces the compartment syndrome. So early features to identify is paresthesia.
Yeah.
Yeah.
Paresthesia and development of pain which is disproportionate. And then the other things like the pallor, the pulselessness, the cold, they are actually late features, isn't it?
They are quite late. The pulselessness is actually very
Yeah.
late. I think most important thing is the absence or or altered sensations. But
Yeah.
in burns, I don't know how you can apply it, because in burns you get a burn of the sensation will not be there. So it's very difficult to assess. I think in burns.
So we are talking
Yeah.
about electrical burns, isn't it? Mainly.
Electrical burns, sir. Yeah.
So you externally you see only sort of one point where electric current had entered,
Yeah.
and not
And
much of a surface burn.
Yeah. And there can be exit wound as well. So in that pathway, there can be, especially this happens in limbs, upper limb and lower limb, the compartment syndrome.
So high degree of suspicion and vigilance should be there.
Yeah.
All registrars and first contact medical officers to recognize early compartment syndrome.
Yeah.
So the earliest feature is paresthesia, not
Yes.
the pulseness, not the pallor, not the dysfunction, but the paresthesia. Is that the take-home message?
And the disproportionate pain on passive, especially passive stretching of the affected muscle group, they can get disproportionate pain. And the other thing, what we do in burns is, because as Aruna mentioned, the paresthesia sometimes can be due to the direct nerve damage. What we do is we feel the compartments externally to see and compare with the normal side to see whether they are relatively tighter compartments. You can feel it sometimes.
Exactly.
And yeah, and then ideal way is to check the compartment pressures. I don't know in Sri Lanka, I have not seen. Aruna, you can elaborate on that.
Yeah. Ideally,
But
we need to check the intercompartment pressures.
But if there's a clinical suspicion, might better to do a compartment release. So that's what, yeah, rather than waiting. So if the patient is having high voltage electrical injury, you see the entry and exit wounds. And if the patient is having paresthesia, and in urine you see the myoglobin coming, and then you check the CPK, and then it's high chance that you know that there's some dead muscle inside the limb. So might as well open the fascia and do a fasciotomy, and if there's dead muscle, then you can debride. So how do you assess the dead muscle is by the color of the muscle, the capillary bleeding, the contractility, and the consistency. So you assess that, and then if the muscle is dead, then might as well you debride. Aruna, you agree with me?
Certainly, yeah, you're quite right. I think they're very low short doing a fasciotomy in these situations.
Yeah. So now when you have a burn wound at the field, still we are at the field, even though I have gone.
You don't do
so what do you do? What do you do for the burn wound at the site? So what you have to do is just to cover with a sheet of polythene. That's more than enough at the site of the burn. So if we at home we have a burn, you don't need to look for various stuff. Just apply a sheet of polythene and come to the hospital. So you know the cling film that you use to cover the food and all that. You can see the lower part of the slide. So the same thing you can apply over a sheet of polythene. That is more than enough. If you have other stuff like paraffin gauze or Vaseline, you can use, but it is not essential because you are coming to a hospital, and then there will be surgeons and doctors who will be management. So this is an interesting slide, sir. We see various this sort of stuff on the burn wound: egg oil, honey, comarica, toothpaste, various stuff. But scientifically, we don't know whether they are really useful. But we should not promote this in the society. What we should promote is just to put water and then come to the hospital, and then whatever the material that we have to use on the wound, we will use it on the hospital. You can see even cow dung, because I have seen people applying mud on the burn wound coming to the hospital. It's really pathetic. They develop septicemia very early. So this should not happen.
I have seen some people putting salts.
Can cause facial burns.
Okay. Now we'll move on to now the patient is in the hospital. And now we have done all the initial assessment, and then we have get the patient to the hospital. And then what we are doing at the emergency is you have to assess two factors. One is the area of the burn and the depth of the burn. So I'm going to now describe how to assess the depth of the burn and to assess the area, the surface area of the burn. So mortality following burn is a function of the percentage body surface area and the percentage of the deep burn and the age of the person. So these are the very important determining factors to say whether this patient is salvageable or not in our setup. How do you assess the area of the burn? There are different methods to assess the area of the burn. We call it TBSA, total burn surface area, burnt. So accurate assessment is important because this assessment is going to guide you to the fluid resuscitation. So one way of assessing is the rule of 9. A person called Wallace has designed this Wallace's rule of 9, which divides the body surface into areas of 9% or multiplies of 9%, except the perineum, which is taken as 1%. So which has a fairly accurate reproducibility. And then for smaller burns, we take the patient's hand, not my hand, the patient's hand, the fingers and the palm as 1%. And then you keep that area on the patient's burn surface area, and then you can calculate. But problem in rule of 9 assessment method is in small children, their body surface proportions are different. They have a smaller lower part of the body, smaller hips, smaller legs, and upper part is larger relatively. So then you have problems in assessment of the burn surface area. Then that can lead to wrong fluid calculations. To avoid that, they have described a method called pediatric rule of 9, but there are better ways of assessing the pediatric burn, which I'll show later. So this is two burn charts which are commonly used. One is the rule of 9 of Wallace's, and then London Broders. So the second one, the London Broders chart, is a bit more accurate because the areas can be further divided as shown in the chart. In pediatric burn assessment, a person called Berko has developed another very complex assessment. You can't by heart all this. It's just the burns unit have this, and then once the burn patient comes, you just mark on the sheet and then calculate. So this is a very accurate way of calculating the burn surface area in children. So we have for adults, it is Wallace's rule of 9s, and then London Broder charts. That's the chart that we use commonly for adults. We can use these for children as well, but for children, because of their body proportions are different, they have developed a better way of, more detailed way of assessing by Berkos. Because correct assessment of the burn surface area is the key to calculate the fluid volume which is required for the patient. Now here in this small child, you can see in the diagram, the head is marked as 18%, whereas in the adult one, the head is marked as 9%. You can see the difference in the proportions. And in rule of 9, each leg is marked as 18%, and in children it is marked as 13.5%. So that's a significant difference. So that's why you need to use these charts or the formulas in assessing the exact burn surface area. So then you have to go for the assessment of the depth of the wound, which is a clinical diagnosis. accurate depth assessment can be difficult in the first 24 hours because burn wound is a dynamic one. Today you see as superficial burns, tomorrow it can look like a deep burn. Today you see as erythema, but tomorrow you see as a superficial burn. So it's a dynamic thing. It can changes. It changes. And in addition to the clinical assessment, people have tried various other things like skin biopsy, dye test, fluorescein, laser, Doppler, and various things which are not commonly used in the clinical practice, but it's the normal, i.e. the pattern recognition. The clinical judgment is used as the assessment tool for the depth. And then most of the time, if you take one particular burn wound, the burn depth is not uniform. It's a mixture of superficial, partial, and deep. So that's another important thing to know about the burn wound. So we broadly categorize the burn wounds into 3 categories. There are subdivisions as well: first degree, second degree, third degree. So we call it first degree the superficial burns. The second degree we call it partial thickness burn, where the part of the dermis is involved in addition to the epidermis. In superficial burns, the epidermis. Full thickness burns, the whole thickness, both epidermis and the dermis is involved in the burn in third degree, and it can go into the deep tissue like fascia, muscle, fat, or viscera. In practice, most of the time what we see is a mixture of depths in one particular wound. So this is a cross-section of the line diagram of the skin showing the depth of the burn. Now you see the superficial burn where you have the epidermis which is burnt and gone, and in second degree, the superficial dermal and then deep dermal, they both are taken as second degree, where the depth is in the dermis. The superficial dermal burn is a second degree, where the superficial part of the dermis is gone. Deep dermal burn is a second degree burn, where deeper part of the dermis is burned. Whereas in full thickness, the whole dermis, epidermis, and part of the subcutaneous or the deep tissues are involved in the burn. So this is very important to identify and to describe the depth of the burn. So I will show you how to identify each of these things. So this is 3 pictures comparing these 3 degrees of burn. The face is the superficial, arm is the second degree or the partial thickness. We call second degree as partial thickness, first degree as superficial, third degree as deep burn. The chest is the deep burn. So I will describe the details of these 3 wounds. Now if you take, now this is to show the erythema. Now you can see these patient's feet. You have some blisters. Just forget the blisters and look around the blister. You see redness. This is called erythema. When you touch, when you press, you see the blanching. But the skin of that area does not peel off. If you wipe with a wet gauze, the skin blanches, but it does not peel off. So that is erythema. This erythema is not taken into the calculation of percentage burn surface area. So that is important. But this erythema, if you don't, this erythema, if you don't manage with proper cooling, it can convert into a superficial burn. So sometimes it is difficult to differentiate the area, whether it's going to be erythema, whether it's going to be superficial burn. But if you see erythema with pain, management is just adequate amount of water irrigation, so that will heal the wound. And then the first degree or the superficial burn, it's a epidermal burn where the dermis is not involved in superficial burn. So you see it as erythematous, it blanches. When you press, you see the capillary refill. Generally, no blisters and minimal edema in the locality. And it's very painful because the nerve endings are exposed. They heal themselves spontaneously in about a week's time. generally 5 to 7 days time, they heal with adequate amount of dressing. This needs dressing to cover and to protect the wound, the wound, but it does heal without any surgical intervention like skin graft. But important to clean this wound by doing a scrub in the theater. They will not leave any scars, but there can be color change for some time. So this is the first degree burn. You can see I have in these patients the upper chest and the neck area. You can see the erythema, and then other area I have removed the skin. You can see a superficial burn. So these are another examples of superficial burns. These are just flash burns, like for example, sudden explosion of gas. It generates flame, and in fraction of a second, everything goes off. So just a brief exposure to heat, it causes superficial burn. And then when you come to the partial thickness or the second degree, we divide this second degree burn into superficial partial thickness burns and deep partial thickness. So if I go back to the slide on the skin, so you can see the superficial dermal, deep dermal. So they are both involving the dermis, but to a different degree. So second degree burns, again, is divided to superficial, partial, deep partial. So this is actually a way of that. This is how, as plastic surgeon, this is what we describe, because it's important to predict the duration of healing and the amount of dressing and all that. It's important for us to know. So that's why we divide this like this. And in superficial partial thickness, epidermis is completely burned, and the superficial part of the dermis, that is the papillary dermis, is burnt, and there are a lot of skin appendages remaining. So they will heal 1 to 3 weeks time. They will heal, and they will be painful. There will be erythematous blanching. They have a blister. Surface looks moist and pink. But in deep partial thickness, where there's more dermis is burnt, it has gone to the reticular dermis and then some domes of the subcutaneous layer, and it can take about 35 days to heal. Sometimes it might not heal, and it can turn into a deep burn. And they are also painful. They have a blister, they are moist, and then pinkish to white. And sometimes you can see mottling also. Hallmark of second degree burn is formation of blister. So I describe a bit more about the second degree burn here in this slide. So epidermis and superficial part of the dermis is burned, and then the skin inflammatory edema collect under the dead skin layer, forming the blister. So the surface part of the blister is dead tissue. There's no viability, so it has to go. And then when you burst the blister, you expose the dermis, and then this dermis, the fresh raw dermis, has to be protected from a good amount of dressing. Otherwise, it can desiccate and it can die. So, and then if it happens, then it converts into a deep burn. So exposed papillary dermis looks very pink, and then there are a lot of nerve endings, then it causes significant pain. And then in healing, these wounds will heal from the edge as well as the bases of adnexal structures like hair follicles, glands. The bases are remaining, so the epithelial buds will sprout from the remaining adnexal bases and then epithelialize. So these wounds, provided you give adequate amount of dressing, they will heal with spontaneous epithelialization. If infection sets in, then they can convert into a deep burn. Generally, these wounds, if they heal early, say within first 2 weeks time, they will not have scarring, but there can be color change because of the damage to the melanocytes. Now, these are superficial partial thickness. That means the second degree superficial variety. You can see the blisters. The blister is the hallmark. When you remove the, you see the pink, and it blanches, and then some areas are you can see the mottling. And when you comes to the third degree burns, so these are we call it deep, this is deep partial, that is the second degree deep variety. So here the injuries gone up to the deep dermal plane, and sometimes the DOMS of the subcutaneous fat is also involved. And then the lesser degree of remaining adnexal structures, so the degree of the rate of healing is lesser than the superficial partial thickness because of the less surviving epithelial elements. Capillary refill is relatively sluggish compared to the superficial partial thickness. Still, they'll have tissue edema, they'll have blisters, and then they'll have dark pink to mottled appearance. So if I go back to the initial pictures, now you can see in the middle picture, compared to the first picture, the face and the arm, you can see the variation that I discussed. And then I'm going to the deep one, where you see the pale, dry, leathery skin. So these are deep dermal burns, full thickness or the third degree burn. They are the severe variety. They will not heal spontaneously because all the epithelial elements are all dead and gone. And even if they heal, they take long time, and then they produce a significant amount of scarring. And sometimes they'll have blisters, and if there are deep reticular dermis is there, then it will look as red and blotchy. And because of the blood vessels in the dermis is burnt and damaged, there will be extravasation of hemoglobin, and then there will not be any capillary refill to see on the wounds, and their nerves are burnt and damaged, and there will not be pain sensation in these wounds. So in deep burns, they are pale, no capillary refill, leathery to touch, and they are asensate. So those are the features to identify a deep burn. So if I go back to the clinical pictures again, now if you remember the description that I had, the deep burns, the dry and asensate, no capillary refill, it's all pale, no blood supply. The deep burn, the chest, the third picture. Are they clear?
Yeah.
Yeah.
Can we ask them if there are any questions? Then what is your next? You are moving to more management after this, or?
Yeah. Then I think maybe another. I don't know. Can I just check the number of slides?
Okay. Shall we ask from a medical student?
Yeah.
Now, from any medical student.
Yeah.
This may be asked in the exam also. Right. Okay. What are the what are the basic documentation you do when you get a major burn patients? You are the first contact medical officer, right? What are the things you document when you see initially see and examine this patient on the bed head ticket? Is the question clear?
Yeah.
A patient following major thermal burns comes to the emergency department, right? And you examine the patient, right? Do your ABC, right? That is also important, isn't it, Kolida?
Yes, sir. Yeah.
And so what are the things in relation to the burns you document in the bed head ticket, which you think it is very important for the further management?
I think we discussed all that. Can someone
Yeah.
answer without wasting time?
Just enumerate.
Mistake.
At least the registrar. Medical students will not raise voice, I suppose.
No, we have yes.
Finally, a medical students waiting exam.
Sir, when the patient comes, as soon as after we are intervened, the documentation starts with the time the patient arrived, and after the history. And
it is more important, it is the time patient arrived to the hospital or the time of the burn?
Time of the burn, sir.
Right, okay.
the time is the most important thing.
Right.
The
Okay, we agree.
intervention. Then after that, how we intervened and what we have done, the interventions we have taken.
Is the type of burn, is it important?
Can you tell
Yes,
1,
sir.
2, 3, 4, 5? These are the things.
Right.
Right. So
Time of
first,
the burn, the type of
Type
the
of-
burn.
type of the burn is important, sir.
Right. Okay. Then
Then how the burn happened.
that is called type of the burn. No?
Then the surface area involved,
Okay. Right. Surface area of the burn.
the depth of the burn,
Right. Depth of the burn.
and whether there is any inhalation injuries, and how the main vital signs of the patient was at the time of presentation, and how it progressed with time.
Okay. Initially, sort of the vital parameters. Right. Is the tetanus immunization? Is it important, Kolita?
Yes, it is important.
Right. So in addition to that, I think that is also important. So when the burn occurs and the type of burn, burn surface area, depth of burn, and tetanus immunization, vital parameters, and special burns, whether he had inhalation injuries or not. So those things should be bare minimum which they should document in the bed head ticket. Anything to be added, Kolita?
I think, sir, most of the stuff that you mentioned, I'll be discussing in, actually, I'm just reaching the halfway of our talk. So about 65.
I thought we have already discussed those things.
No, sir, about 65 slides more to go.
No. The things, the
Yeah.
initial documentation.
Yeah, initial documentation, yeah. Rohan, now, shall I break this and then shall we do it on another day or maybe tomorrow?
I think so, because otherwise these people will not grasp. So we'll come to maybe
So-
1 point. But
Yeah, let
Okay.
me go through 3 or 4 slides, and then when we start, we will go to the management from tomorrow.
yeah, okay. So shall
Right. So before you move, the burn surface area is basically assessed by using different charts. It's a calculation, and depth of burn is assessed by clinically.
Yes.
Okay. And you said sort of, all right. Okay, we'll move from there.
So this is a, we were discussing about 3rd-degree burn. So this is a picture of a 3rd-degree burn. You see pale, leathery, dry skin, which does not have capillary refill. And there's, when you check for pain, it's painless. And then as it burn further, and if there's a deeper burn than this, it destroys both layers of skin, the epidermis and skin, and it goes to the deep tissue like fat, fascia, tendons, and muscles, sometimes even the viscera. And it can go into the underlying structures. And then the surface will look like dense white, waxy or charred appearance. And where you get whatever the structures involved in that area will get necrose. So then ultimately what is produced is a ESCA. It's a coagulated dead skin. It's like a piece of leather, asensate leather. So this is what you see classically on these 2 hands. The classic leathery, asensate, pale, waxy skin, which is dry. No capillary refill. So this is very important to recognize. These wounds will never heal with dressings. They need surgical intervention in terms of removing the dead part and then putting skin graft. So we will discuss it probably tomorrow. So these are more examples of full thickness, 4th degree. Actually, they are 4th degree burns. And then I'll discuss on this and then stop for today. The burn patterns, because most of the burns you see are accidental burns due to some sort of non-intentional action. Sometimes you see burns as intentional, non-accidental burns, maybe self-immolation or homicide, assault in children, non-accidental injuries, and you call them a suspicious pattern. Most of the time when you get the history, it's very important to ask what happened exactly, and then check with your common sense whether this is compatible with the pattern of injury to the given history. This is actually forensic medicine. So, so these are three pictures of accidental burns where these patients express the way or the mechanism of injury which is very compatible with the wound. So these are accidental burns. If you take these ones, these two, now the person in the first picture with a face and head and neck burn. This is a classic acid assault burn. So this is a assault. It's not an accidental burn. One in the middle is actually a burn only on the back of the body, and this is when he was intoxicated, he was burnt from behind. So this is a assault again. And the third picture, what you can see there is a mark of a iron. The smoothing clothing iron is somebody has kept the hot iron on the back of this patient. So these are intentional. They are medical legal cases. So it's important to identify, and then as house officers, you have to get the proper history document, and then you have to inform the police and judicial medical officers for the necessary further action. So these are the classic appearance of self-immolation burns in our setup. What they do is they put the kerosene oil or petrol, we call it accelerant agent, onto the upper part of the body, especially to the chest area, and then they set fire. And so basically their upper part of the body is involved and mostly symmetrical, and then there's no attempt of extinguishing the flame. So they just run and then crying and running, and no attempt of extinguish, no attempt of cooling the burn. So they are all full thickness burns. So these two pictures are of self-immolation burn. So most of Sri Lankan setup, major burns are due to self-immolation. So now when you have a burn patient, there are admission or referral criteria to a burn center. So these are any burn greater than 10% burn surface area. If the full thickness burn involving more than 5%, burn in special areas, face, hands, feet, genitalia, perineum, across major joints, and circumferential burns, chest burns. So they need admission. Burns, even smaller percentage with inhalation injury, especially when they happen in enclosed spaces like inside a burning room or house or a garage, something like that. Electrical burn, even though they are smaller in percentage, they need, because they need cardiac assessment, and then they need assessment for the compartment syndrome and development of acute kidney injury due to myoglobinuria. Chemical burns, burns with pre-existing illness, for example, diabetes, CVA, burns associated with other trauma, maybe cervical spine injury, maybe fracture, maybe bleeding wound, maybe laceration, maybe head injury, because you have to attend to the other injuries. And burns at the extremes of age, very small children and then all elderly people, burns in pregnant female, and all non-accidental burns. That's why you need to identify the intention of the burn, whether they are accidental or non-accidental burns. So if you have all these, if you have one of these criteria, so these patients need admission for further evaluation and management. I think, Rohan, another about 60 slides to go. So probably we'll take a break today and then give me a time tomorrow, then we will
Yes.
proceed.
Call it a few questions. not few. Now, in this classification of the depth of burns,
Yeah.
We are not actually considering the whether the muscles are burned, whether the bones are burned. I mean, beyond third degree, there is nothing. All you consider in the same category. Is
Yeah,
that-
actually, there are two ways of burn classification. The American way of classification is the first degree, second degree, third degree, fourth degree. But in some of the burn textbooks, they don't talk about fourth degree. They just stop at third degree. And in the Australian, New Zealand way of burn is they call superficial burns, superficial partial, deep partial, deep dermal, and then full thickness. So in that full thickness, it's actually the fourth degree. So I actually simplified the classification, because in Australian, New Zealand way, they categorize the depth assessment into 5 categories. So it's a bit complex. For us, it is actually because we are being using that, but for a beginner, it will be, I think, easy to remember as first degree, second degree, third degree, and superficial, partial, and deep. So we cover both. So I just merge both classifications together in the presentation, because
And,
some of the journals and books, they give both.
And the clinical implication of the surface area of the burn is for the immediate management of the fluid resuscitation.
Fluid resuscitation.
And the depth of the burn is the prognostic and the dressings.
Yes.
And the scar formation and how long he's going to be in the hospital and what form of deformities he's going to end up in.
Yeah.
So both have sort of two different clinical implications. Right. So any registrar can summarize what Kolita has said so far?
From the beginning, if can someone summarize, one of our guys?
You mean one of the consultants or the senior registrar or registrar?
Our senior registrar.
Okay, basically, anyone sort of help me, senior registrar or registrar. I think Kolita just explained initially different basic types of burns, isn't it? What are those basic types of burns?
So you have chemical burns, you have thermal burns, you have electrical burns. Those are the types of basic types.
Okay, those are the 3 main types of burn he described.
Yes.
Then he said sort of, he brought a pathological model of the burn that was very important in the management and understanding of the management of burn. So what are the 3 main areas of burn which you get?
Yes. The Daxon model has 3 zones, basically. Yeah. Zone of coagulation, zone of stasis, zone of hyperemia. Zone of coagulation is in the middle. Surrounding that, you have the zone of stasis, zone of hyperemia. So our sole objective.
What is your main objective in the management of burn?
Yeah, main objective is to preserve the extension of burn injury to zone of stasis and zone of hyperemia.
Right. So what are the principles of managing burns, whether it is thermal burn, chemical burn, or electrical burn? Mainly sort of just enumerate the principles of management of burns.
Yeah, the main message that he want to convey is that burn management starts with the pre-hospital area where the burn is sustained. So if we categorize the main parts of management, you have pre-hospital care, you have initial resuscitation in the hospital, you have bone assessment, and then you have subsequent fluid management according to the surface area, and then you have wound care. And then you have the controlling the metabolic response. He talked about controlling the nutritional optimization, controlling infection, and very importantly, identification and managing any inhalation injury, and then subsequently scar, contracture, deformity management, and then patient psychosocial problems addressing, and then medical legal aspect, and then the management. So those are the basic management areas that he spoke about.
Okay, I would try to categorize sort of them considering both pre-hospital and hospital management together. The first most important thing is to avoid or limit any further burns, right? So for that you may do whether it is thermal burn or chemical burn, irrigation. Very simple. You use tap water irrigation, running water irrigation, right? That is to prevent any further progression of burn. Then assessment of burn. So he said sort of assessment of burn involves mainly the depth and the surface area of the burn, and assessment of any associated other injuries, because this is a major thing. ABC come into that. Or his other comorbidities, age, those things. Then the fluid resuscitation, which comes into practice, and the dressings. Then he said about, he mentioned in his initial this thing, the nutrition and infection control. Then he was talking about rehabilitation and everything about the rehabilitation, the plastic surgeon's role in real plastic surgeon's role in burns comes there, he said. Then in the middle he was telling about, so those are the principles, I suppose, in managing burns, but especially he said in electrical burns, we should pay more attention for the of the possibility of developing early compartments in eye burns. He emphasized a little more about the irrigation and sort of how to irrigate it. Again, principle is irrigation, whatever the site or the modality of the burn.
One more thing to answer about pathophysiology. What is special about burns is that it is a dynamic, unlike other wounds.
Yeah.
It's a dynamic injury. It can change. What you see now may not be the actual injury that you see after some time, and some of that can be reversed. And if you don't manage, that can can progress very fast. That is one special thing from the presentation that I picked up about the pathophysiology. And also
and the first 24 hours, he said sort of these dynamic changes occur, and up to the first 3 hours is the more crucial part where we can actively do something to prevent any further burn.
And even after that, because of infections, still it can remodel and change. And that is one. And also the inflammatory response that we see with burns is quite disproportionate. So initially it can be local response, but then it can spill out and it can be a general response. But unlike in other wounds, even without, now other wounds become septic and they get systemic response. But in burns, even without sepsis, early they can get generalized response. Isn't it, Kolida?
Yeah.
Yeah.
Burn itself causes systemic inflammatory response without infection.
Yeah, that is very important. Medical students, are there any questions from this part of the talk?
So is there any place for limb elevation in the pre-hospital care of the management, sir?
Yes, you can do that, but what we as part of edema management that we will discuss tomorrow, we do positional changes to reduce edema. If the burn is involved in the upper limb, you elevate the upper limb. If it is in the lower limb, you elevate the lower limb. So those things actually we do as part of the hospital management, not as the pre-hospital management. In the pre-hospital management, there are two important factors: stop the burning process and then cool the burn or dilute the burn.
I have a question regarding the transportation of the patient from the pre-hospital to the hospital setting. So is there anything important or any procedure of any way, proper way, things we should consider regarding?
As for any form of trauma, say if you are suspecting spinal injury, you know the way patient with spinal injury is transferred, isn't it?
Yes.
So depending on the patient's, for burns, there's no specific way. Just cover the burn wound with some polythene, and then the important thing is before you bring the patient at the site of injury, you have to cool the burn. You don't bring the patient to hospital to cool the burn. You cool the burn and then bring the patient to the hospital.
you, sir.
Yeah. So when you ask questions, just mention your name and the batch, or maybe a medical student, the registrar, the consultant. Just tell who the question is asked, or the person who's asking the question. Yeah. Are there any questions? Other questions?
So I'm registrar of Dr. Ranjit Jayasekara. Regarding chemical burns, is it always advisable to rinse with water, because some chemicals can form either acid or alkaline after mixing with this water,
For example,
like sodium, bromine, especially in laboratories.
yeah, the one reacts with water that I know is sodium. If you say the metal sodium,
Yeah.
when you touch metal sodium, you won't burn. If you touches water, it burns.
Like bromines, it can form like hydrogen bromide and further damage.
I really don't know about that, but I'll read on that. But I know there are instances that you may not be able to use water. But can you find it out what exactly has to be done in such cases in bromide?
Okay.
Excuse me, sir.
Yeah.
Sir, I have a question, sir. Sir, in an occasion where somebody has intentionally put concentrated acid on another person's body,
Yeah.
In A levels that we have told the dilutional enthalpy by adding water is more than the dilutional enthalpy of adding alkaline or something. So they told that when there is diluting with the water, concentrated acid, the more heat is generating than dilution with normal alkaline. So it will cause more damage. So without putting water, bring the patient to the hospital, sir. Is it correct, sir?
That is wrong, because how do you know the strength of the injurious acid?
Yes, sir.
And how do you know? Now you can't do a laboratory test to find out the exact amount of alkali that you need to neutralize the X amount of strength acid. You don't know that. So in laboratory setup, if you know the strength of the acid, then you can calculate the strength of the alkali, and then you can mix to neutralize. But acid and alkali reaction, aren't they thermogenic? Acid and alkali mixing, they are thermogenic, isn't it?
Sir, that I heard that it is better to put a weak base like sodium bicarbonate or calcium hydroxide. So as calcium bicarbonate, so as it is a weak base, it will be not problem, sir.
Yeah.
Is it correct, sir?
In hospital practical setup, what we get is actually a chemical burn. We don't know what chemical has caused the burn.
Yes, sir.
So even when they come from the community, it's very difficult to find out what exactly is causing the injury. We don't know the chemical. We don't know its strength. Theoretically, what you are telling is correct according to the book, but in real life practical setup, we don't know what has caused the burn. So what we have to do is to dilute.
You can't find the acid that neutralizes that.
Yeah, because when somebody is assaulted acid on the road, you don't know what has come onto your body.
And then you can't find the real acid to neutralize that. So that is a very theoretical thing that we have heard from someone who's not practiced.
Yeah.
So in practice, that is not applicable. When you are
principles of management of burns. You know, these are the basic principles and guidelines. Whether it is chemical burn or a thermal burn, you prevent further thermal injury by diluting it, by irrigating with water. There may be better solutions if we know exactly what it is, and if the neutralizing solutions are also available with us. So in usual scenario, we don't have it, we don't know it. So the best guidelines are to sort of manage 90% of the patients in general setting. And the first question he asked, sort of when it is burnt with sodium or sort of bromide. So most of these chemical compounds come with safety leaflets. They say exact antidotes to be used and how should be neutralized. And if those things are available at that time, of course we can do it. And especially with these solid chemicals, what they say is sort of get rid of that. So remove it from the surface. And if there is antidote, you can use it. But whenever sort of it is not available, these guidelines will help you to sort of minimize further injury. Is it correct, Polita?
Yes, exactly. So this is actually a guideline or a principle that we are discussing. So individual chemicals and minor details we will not be able to, and even I really don't know the management of all chemical burns, because we have to refer in certain situations. But in real life situation, what a majority, 95 to 98% of the time, we don't know what has caused the injury. So according to the management principle that we can do for majority, we use irrigation. So that is the recommendation.
Yes, sir.
So,
Thank you very much, sir.
I'm from surgical staff from Andis's side. So just to add that, what I think, sir, the concept is running water. So at that point, whenever some heat is generated, that can be washed out with the running water. So I think that running water is more appropriate than just water. No,
Yeah, exactly. Agreed.
So what is the reason for tapping the surface with the polythene, sir? The burn area?
Just to have a barrier cover till the patient comes to the hospital, to have the proper. It's just a transport dressing.
So sometimes the heat can cause the polythene to the
No, this is after cooling the burn. This is after cooling. Yeah, you don't put polythene onto the burn wound, burning wound. This is after cooling the burn.
Okay, thank you.
Yeah, this is just a transport dressing, because when you say put this and put that to the wound, and it causes a lot of confusion. So simple way is to just to cover with some polythene, and then it's easy to find. Every house we have polythene, isn't it?
Sir, initially you mentioned about the de-roofing of the burn blisters.
Yeah.
Sir, is it the same thing we done in infective blisters? You get in cellulitis and things?
Yeah, similar. Tomorrow actually we will discuss. I'll show you that if you are seeing the screen, this is what we do: the initial scrub and then the dressing.
Should that be done in the emergency department or in the theatre?
Ideally, theatre, sir.
Right. So without de-roofing, you will not be able to assess the depth of the wound properly.
You can't assess the depth.
So depth is then assessed by assessing the theatre.
Yeah.
Okay.
About the polythene question about the polythene that the student asked, you said it is just to cover. I think my cover is to prevent the contamination.
Prevent the contamination. Yeah.
Transport, and does it reduce the fluid loss?
No, it does not. The one advantage of having polythene is when you have the polythene, the moment the patient comes, you can see the wound. It's a see-through, and it's a barrier for infection and contamination.
Okay.
Yeah. Because if you put gauze and cloth, now cloth and gauze, you can't see the wound through that. You have to remove it. Then you, in the emergency department, for you to assess the extent, then you have to remove the dressing. Sometimes when you have a smaller burn in the limb, you sometimes see a big bandage covering the whole limb. Then you can't exactly assess. So that's why we prefer to have something like that.
Excuse me, sir.
Yeah.
Sir, from the site of burn until the patient is admitted to the hospital, is there any method to reduce the pain from the burn, sir?
Yeah, if you have facilities, you can give some analgesics, but best analgesic at the site of burn is water.
Irrigation.
Okay.
Irrigation.
Okay, sir.
So they're asking whether can you give Panadol or maybe NSA?
Yeah. No problem. If you have facilities, then you can give some.
Yes.
Sir, I have a small question, sir.
Yeah, can you talk a little loud? Yeah.
Sir, I have a small question, sir. Sir, apart from the...
Can you introduce yourself?
I'm a final year medical student, sir.
Very good.
Sir, apart from the inflammatory response, does it also lead to gut ischemia, which can lead to reduction in the absorption, which can be fatal?
I didn't get the question. The low.
Can you tell it a little loud?
Sir, apart from the inflammatory response in burns, does it also give rise to a reduction in the absorption due to gut ischemia?
Due to?
Gut ischemia?
Gut ischemia.
Yes.
Gut ischemia, yeah. If there's significant hypovolemic shock, then gut can be ischemic, isn't it? Rohan maybe or Samudra sir may be better in describing that than me.
You mean absorption of nutrition or sort of absorption of toxins? Mucosal ischemia breaches the gut barrier, so it promotes absorption of more toxins, and the absorption of nutrition is also compromised. But nutrition is not an acute problem here, and we can sort of provide nutrition in other means as well. But more important thing is that of the toxins. So that is a problem, and in addition to that, the gut ischemia can lead to mucosal injury as well. This is more manifested as peptic ulcers. So that is why you get more peptic ulcers, or it is common following major burns.
I think what he asked, the question was not very clear to me. What he asked was, I think the acute inflammatory response that you get because of burns, can it cause gut ischemia? I think that is what he asked. I think that is why we resuscitate the hypovolemia and hypotension that can cause gut ischemia, and you resuscitate to prevent that. I think that is what I gathered. I'm not sure what exactly he asked.
Yes, sir. That's what it is.
Yeah.
Thank you, sir.
Purpose of fluid resuscitation is to maintain the perfusion at cellular level for all tissue, not only the skin, the whole body tissue. But we will be measuring the adequacy of fluid resuscitation with the urine output. But purpose of resuscitation is to provide adequate tissue perfusion at the cellular level to all the tissue, even though we don't discuss separately about brain, separately about bone, separately about gut. It's for all tissue in the body. Because if you develop hypovolemia, hypotension, it's a systemic problem. No?
Yeah. Any other questions?
Sir, regarding the admission criteria, sir, are they the burns greater than 10% of total body surface area? Are they same for the pediatric population also, sir? Is that
yeah. Same.
Yes, sir.
So these are actually these are not rules. These are just guidelines. So the things can change. But say if the patient is having 8% burn, and if there's no person to help him at home, if the patient is living alone at home due to social reasons, then we have to admit. No? So likewise, these are just guidelines, and the individual patient has to be managed individually.
And so in some places, they have mentioned that the cooling is only affected up to 1 hour, sir. Is that true, sir? In different places, some says 3. Most of the places they say 3 hours. At one place I saw it has only 1 hour, sir.
Yeah. Now there are no 100% uniform concepts. Now, if you take fluid management also, different burns unit in different parts of the world use different formula. Some people use Parkland. Some people use half of the Parkland. Some people use only crystalloid. Some people use other solutions. So there's no uniform 100% consensus about any of these things. some people don't give antibiotic prophylactically. Some people give antibiotic prophylactically. Some patients, some people's admission criteria varies. Some because of their facilities at community. Now, if they have district nurses or GPs to manage burns at their locality, then the admission criteria will change. So these are just guidelines, and this is not just a sort of blanket rule for everything. So these are just help for the management, not real rules.
Yeah,
if you take a wound, say patient is having a leg wound, there are hundreds and hundreds of material that people use for the wound management. Ultimately, whatever you use, wound will heal. So there's no rule to say that this particular wound needs this particular material to dress. So in medicine, it's like that. So based on the clinical experience, the situation, the patient's factors, the local factors, then we have to use it. So I think in any of the management lines, there are no 100% consensus. So various people have done various research, and then they have described. So according to the Australian New Zealand Burns Association, so that's why they have given 3 hours. So that's why I'm using that.
So basically, the principle is if they come early enough, cooling using running water is the way to reduce further burn injury. And it is running water, but not keeping under a fan.
Yes.
In medicine, there are certain instances where you stick to principles. Now, the question that you asked, whether it is 1 hour, 2 hour, 3 hour, no one can prove that. Let's say you do randomized trial, you can't do trials like that, and there's no point in doing a trial to find out whether the 1 hour, 2 hour, 3 hour is effective. I mean, it doesn't make a big difference. So in these instances, you stick to principles. The principle is early cooling. Whether it is 1 hour, 2 hour, it doesn't matter. And no one will question on that. You won't be questioned on in points like that.
Okay, sir. Thank you, sir.
But that doesn't mean we don't encourage you asking that question.
Yes, exactly.
We just sort of, that's a good question, but it is important to understand the thinking process behind this thing, right? Even when we are setting a question also, we will not ask sort of whether it is 1 hour or 3 hours, but we will ask probably, is it important to avoid further burn injury? That is important, and how it is being achieved by running water. Right? Or if you are sort of the best answer is running water, applying ice, or keeping under a fan, right? So the expected answer is running water.
Okay, is that all? Anything else? Any other questions?
Sir, regarding documentation,
yes.
Is it important to mention about the environment?
Is it a register or medical student or?
Sir, I'm Hasini from batch 25.
Yeah.
Is it important to mention regarding the environment, like a closed room, to suspect any systemic poisoning, like carbon monoxide?
Yeah, so that's very important. So I have included that in the inhalational burn part. If you go there, enclosed spaces. Can you see the slide?
Yes, sir.
So yeah, so that is included. Yes, important to document, find out.
All right, so thank you.
That's all. Okay, no more questions. Next half tomorrow, is it okay?
Yeah, I'm ready. Never you say.
Right. So probably we'll time maybe around the same time.
Yeah, you tell me.
Okay. Can one of the medical students thank stopped up only because he's
participating this in the auspicious time. Oh, it's not yet, no? පුණ්‍ය කටයුතු වල නේ දෙන්න කිව්වේ. මේ වෙලාවේ.
එකක් ඒව තමයි.
කටයුතු.
Okay, thank you, Paul. Thank you very
Thank
much.
you, sir. Thank you very much, Rohan. Thank you for the opportunity. We'll meet tomorrow.
We'll stop for today and we'll meet up tomorrow. Okay.
Thanks. See you guys.